All right, we're going to start with emergency medical responder. We'll start with Chapter 1, EMS Systems. Now, when we're talking about this, EMS systems, uh, the National EMS Education Standard competencies are what is going to prepare you now to be a medical provider in the state of Michigan and beyond if you want to. It uses simple knowledge and common sense, basically. We're also going to talk quite a bit about safety during this class and how we're going to take care of each other at the scene. At the scene. Okay, some of the competencies that NEMSIS takes into consideration are what are the individual systems, what are our roles and responsibilities of uh, you as an EMR, and then expand it out to as part of the system, and then what does quality improvement mean? Well, how are we going to get better, not only as EMRs, but also as a system? We're going to talk a little bit about research and the impact that it has uh, on developments of new techniques and treatments, and your responsibility and data collection and what we have to do here to make sure that the patient is well cared for long after they've left us. And then finally, there is a public health component to your job as an EMR. All right, so let's get started. Most of the time, when we talk about EMRs, they are the first ones on scene. They're the ones that are normally dispatched first because ambulances will be a little bit farther away and stabilize the scene and get things started. Follow ups, more and more the EMTs are showing up on basic trucks, but we also have the AEMTs, the advanced EMTs, and the paramedics that will be also showing up. We've been used to having paramedics on the ambulance, if you will, but now we're seeing a return to the basics, which is quite frankly you. A legal basic ambulance requires one EMT and a minimum of one EMR. So technically speaking, you could run on a basic truck. So your roles and responsibilities is much like the way it used to be. And then finally, we'll have some nurses and physicians, obviously, as we deliver these people to the hospital. You might be part of that direct transfer, maybe you only see them at the ambulance and the patients, that is. And then, of course, in the system itself, there's other allied healthcare professionals like OT, PT, X-ray, um, all of the rehab type things that go on there. So in a system, we initiate a system access by first having somebody report that there's a problem. Something's going on, right? And so someone reports it, dispatch gets it, and sends out the first responding units. Now that might be you, most likely it will be, and then sending out also the first ambulance that's coming out. Also with that, you have your basic ambulance or your paramedic ambulance, your ALS for advanced life support, or your BLS for your EMTs, right? And they come on scene. You might have one or both on scene, depending on what the situation is. And then it gets over to the hospital, and then, of course, we just start doing the follow up. It's imperative that each person know their job and each person do their job. So let's break it down a little bit more. Obviously, you see here a young man that has a hurt leg of some kind, and there's somebody there with him, looks like on the street somewhere, and they're calling it in. Okay, and it's you might hear PSAPs, the Public Safety Answering Point. We call that 911, obviously, but there's been some problems uh, lately with communications and blackouts and errors and this and that. So this might be the old 7-digit phone call that you do, right? Dispatch gets a hold of it, and there is a whole system there. The dispatcher answers the phone, and most of them have like a dispatch card system that they go through, and they ask questions, and then they send out the appropriate resources. It takes a moment longer, but then it gets you exactly what you need rather than resources that you don't. Okay. Typically, the phone calls come in via telephone, standard landline, which is becoming a thing in the past, and cellular phone. Uh, then, once the dispatcher gets a hold of it, 99% of the time, they hit a button on their console there, and it pages out the responders that are going to be going to that direct scene. Okay. You have computer stuff, CAD. Law enforcement uses that a lot. We're trying to make a switch to do more CAD dispatching for EMS and fire. Typically, that's going to be for your full timers, not necessarily for your paid on calls. You can see here in the upper left-hand corner, and even in the lower, the upper left-hand corner, or even the lower left-hand corner, there's some serious issues going on there. The first people on scene, the firefighters, law enforcement personnel, so they have to make some decisions very rapidly about what's going on and start appropriate training, get additional resources coming in, right? This isn't to just show up and run around until the ambulance gets there. There's a lot of work to be done here, and especially in some of these bigger incidences. Now, again, a basic ambulance, and maybe this is a point where you want to take a quick note. Basic ambulance, a BLS truck, is staffed by no less than an EMT and an EMR. That's your minimum requirement. Okay. Now, for your ALS truck, the minimum requirement for a legal ALS truck is one paramedic and one EMT. Now, there are 4 levels of license pre-hospital. One is the EMR, that's the first level. As you move up a level, that's the EMT. As you move up a level, it's the advanced EMT. As you move up a level, it's the paramedic. And there's only those 4 pre-hospital medical licenses out there. Okay? And so that is the levels, if you will. You may receive, if you're a patient, care from everyone, but the order this goes is EMR, EMT, AEMT, and paramedic. Okay? And it's important to remember that. We have to know our job. We have to do our job. And each level builds on the previous level. Now, you can just take an EMT course. You don't have to take an EMR course. The difference is EMR is about 100 hours less, and EMRs don't transport. We don't have as much in the way of interventions that we can do as well. Okay? But all levels are based starting here at the EMR level. We start with A, B, C's. Airway maintenance, how's our breathing doing, how's our bleeding control going on. And we're also talking about preventing additional errors and issues for the patient, understanding what's going on with them, and treating for life-threatening conditions like shock. Once we've gone through the initial contact, once we've gone through the ambulance transport, then the patient comes through into the final section, if you will, of the EMS system, and that's the hospital. Now, it could be direct to ER, they get patched up there and they leave. But other things that might happen is they have to go to a specialty center for whatever reason. Now, listed here are what? 1, 2, 3, 4, 5, 6, 7, 8, 9 different specialized facilities. You have trauma centers and spinal cord injury centers and all this stuff. So if your patient has a specific injury or illness or condition, they're going to go to a specialty hospital. To send a person who's pregnant and getting to the point of depregnification, a term coined by me, uh, you wouldn't send them to a stroke center. And you wouldn't send somebody with a heart issue to a pediatric center. Now, yes, maybe they're the same hospital, but you get my point. We've got to be thinking and helping the transporting units know the appropriate ways to go. And it's okay to say, hey, I think this or I think that. And when we start talking about what does it mean to be, for EMS to be in public health, uh, we have a responsibility, right, uh, to monitor cleanliness. Now, this one here, this specifically says restaurant cleanliness. I'm not really sure why they put restaurant in there, but cleanliness in general, immunization programs in general, uh, contagious disease tracking, right? Prevention. All of these things are part of our mandate, if you will, for public health. We don't just go storming Norman into places, bull in a china shop, and ignore the things that we're seeing. If we see something, quite frankly, we need to say something. We also do help the public in their car seat installations, right? Through the car seat installation program. We want to make sure that those pediatric patients are safe. We want to encourage good seatbelt use and alcohol awareness. All of these things, right? Um, Especially the motorcycle helmet. Now, with motorcycles, I think they're cool, and I really respect those people that are driving them because they're really out there freewheeling it, if you will. But helmets will be the difference between saving a life or having a funeral, right? So helmets may not look cool, but they are good for the old noodle in there. We like to do blood pressure screenings. Senior centers love that kind of thing. And diabetic screenings, we could add that to the blood pressure. You like to do a vital signs screening. That's why vital signs, one of the things that vital signs are good for is you can reach out to the community and say, hey, community, I want to help you. And I'm an or EMR, I'm with the rescue squad, and I just want to make sure that you're safe and you're well. And then provide them with information. Where am I going next? What hospital would I go to? What ER would I go to? What doctor might I look up? Right now, it's interesting sometimes to look backwards and see where we came from. And when we look back to see where we came from, it'll be easier for us to know where we're going. In the 1950s and 60s, funeral homes were your primary ambulance, if you will. And the hearse, the people that worked the funeral home, would receive a call. Someone would call their facility, and they would get into their hearse, their ambulance, and they'd go screaming out to wherever this patient was. And if they were alive, they'd get thrown on the cot, and they'd go screaming to the hospital. But if they weren't, if they had already passed away, they'd put them on the cot and drive normal traffic and go back to the funeral home. So awkward. When you saw this vehicle roll up, you were not happy to see it, right? Now, for us, our hospital care systems, if you will, really are behind most of the time. Uh, the military took care of their patients way better. They would have field hospitals and transport units and so forth, litters, if you will. And our civilian mindset took a while to catch up. Then in 1966, there was an article published. And this paper showed the deficiencies in care, in medical care being given pre-hospital. And that caused the United States Department of Transportation to develop the first ever training programs. It was called EMT ambulance, right? And these people were trained with first aid knowledge to be able to care for the sick and injured before they get to the hospital, right? The first one I think was November of '69, and then it went national in the '70s. Then, as the '80s came into being, early '80s, we come up with this ALS term, which is paramedicine. You know, you remember Rescue Night, Rescue, right? Da 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 emergency. Da 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 da. That was, you know, them from California. But today, as we talk about the training levels, there are so many requirements. There's so much education out there. Uh, we need to be paying attention to new things, new ways of doing things, right? So we're not just ambulance drivers anymore. Now, NHTSA, the National Highway Safety Transport Safety Administration, uh, is in charge now. Okay, that's who's in charge of the EMS, of pre-hospital medical. And there's really 10 things that they do to kind of uh, measure, right? To take care, to see what our medical systems are doing. Number one, they take care of regulation, policy. They write the standards, they write the protocols, they write your scope of practice. Resource management, they train us in how to deploy our resources. Um, then, of course, we've also got our human portion in training, and we have transport equipment and systems. This is what, you know, your ambulance or your rescue, there is a state mandated checklist that each of these vehicles must have on board. Now you can put more stuff on there, but when you do your yearly checkoff with your unit, it has to have these things on. And in the same way, hospitals just can't be a random house. They have to have, you know, positive pressure ventilation or negative pressure. They have to have oxygen. They have to have all of their tools and things, right? Then you need to be able to talk with them. And this communication system needs to be recorded in the event that you need to go back and say, okay, this is what I said. This is what I reported in, right? We also have that portion that we kind of touched on earlier about public information and education. We're going to train the civilians on first aid and on CPR and why to call an ambulance or the rescue team and why not to. When you should just take yourself to your family doctor. There's also medical direction. The person or persons that are in charge of the entirety of uh, pre-hospital care, right? In fact, we have medical direction for this class. It's Dr. Andrea Allman, right, from Lakeview. There's also systems and developments, especially in developing of systems when we talk about mass casualty incidents, where are we transporting patients that are hurt, and then once we're done with everything, an evaluation tool to say, okay, what did we do good? What did we do? What do we need to do better? And what are some things there? What are some takeaways from these calls, these incidents? Now, again, you probably won't be on a transport unit, but they might yank you up in there to assist during it. During transport, like an ambulance shows up, they need another set of hands, and maybe you jump aboard. But a transport is needed when medical professionals, which you're going to be, say that a patient's condition is not good, and is not good in a way that shouldn't take themselves. We need to transport this patient uh, because they're not in good shape, and they really shouldn't take themselves. It could wind up being dangerous. Okay. Now, when we say prompt transport, patient's condition is serious. Patient is going to die without help, right? And so when we're talking during our handoff reports to the EMTs, to the paramedics, hey, this person's in bad shape. We need to get moving here. Okay. We also have rapid transport. So we have prompt transport. Hey, we need to get going, and rapid transport would be um, we need to be in a surgical bay. We need to be we need to be in a location right now that's got multiple dock type things. So to review, let's go back real quick. So we have transport. We have they need to go. We have prompt transport. They really, they need to go now. They can wait for a minute, but got to go now. And then we have rapid transport. They've got to go right this very second. They need to be the first ones out. And we need to let those medical facilities know what's going on. So as people are rolling in, then of course we can make sure that they're transported to the correct medical facility in the correct order, so that everybody has the best chance of survivability. You're going to learn the foundational medical knowledge needs to take care of people. That's what you're doing. That's why you're here, right? You're going to be dividing your skills up into two main groups. You're going to take care of the trauma patients. In the trauma patients, you're going to be worried about airway, breathing, circulation, and circulation as much as controlling bleeding, external bleeding. Training for shock, and we'll talk more about that later, training wounds, splints, and so forth, and bandaging and splinting and slinging and da 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 da. So we're going to do trauma. We also then have medical problems. So you have trauma, anything that is owie boo boo, and then you have the medical, which is then all things that deal with the internals outside of trauma, heart attacks, seizures, uh, poisonings, all of these things listed here. These are medical issues, right? And so we're going to talk about both of these things, um, both trauma skills and medical skills. We want you to be able to, at the end of this course, evaluate, stabilize, and treat patients using minimum resources. We don't want to use up all of our everything on one patient. Okay. Now during class, you're going to know the basics. We're going to work on the basics, but at some point you might have to improvise, right? And we're going to even practice improvisation. Right? And it's important for you to know your job so that you can assist the EMTs, AEMTs, and paramedics in their job. Because again, everything builds off one or the other. Everybody has a little bit more training and a little more knowledge, a different specialty job that they have to do. So if you can take care of your job, it frees up the other licenses to do their jobs. There are things that you need to know not to do. All right? We don't ever just move somebody because we can't. Oh, I'm going to move you because you can't. Okay. There are instances when you shouldn't move them because it would be worse to move them, right? So we need, just because we know a skill, we know a procedure, doesn't mean we're actually going to do that. And another thing that we know we should not do is never judge a patient on their cultural background, religion, color, gender, sexual orientation, age, or socioeconomic status. Now we say that, we know that, but ask yourself, are you non-judgmental? You have to be that way in the field. It doesn't matter what you believe in your heart, how you act in the world. You cannot judge somebody. Your job is to take care of them in a compassionate way, not a judgmental way. And then, of course, you have your own kit. Um, Typically speaking, as an EMR, a little first in bag or whatever. You should know where that stuff is in your bag and be able to utilize this to provide care for people. Now, this kit could be anything, um, but whatever it is, know what you've got, know how to use it. Here's just a quick example of uh, a picture. This is in your textbook on page 9, uh, and it gives a list of all the kind of neat little things that you could put in there. And there are lots more that you could add if you want. And there's things you can take away, whatever. But the point is, know how to use this so that your patients have an opportunity at having a good outcome. And then if you don't have enough equipment, maybe you have too many patients, maybe both, you need to know how to improvise your way around it. What can I use instead? Right? How can I assist other EMS providers? Do I know where their stuff is in their ambulances and rigs? If I know how to do something, maybe I can help a higher level license, even though I'm not technically able to do it. If I can help, I will, right? Now, obviously, we have different uh, settings that we operate in. We have uh, city settings and we have country settings. We have, that's the difference. Urban, right? Urban is city, rural is out in the sticks. I operate from a rural setting. But we also need to know you might have regional differences, topographical differences, and we might have to use different equipment in different places. Now, uh, for us right here, right now, I doubt if we're going to be moving on into different states. But never say never, right? Always be aware of what your area needs at what season that you're in. Okay, and as a side note to that, if you're one that is going to move states, you might have to have additional skills that you train for. For instance, uh, iGel is a skill in the state of Michigan that you might not necessarily take to another state. It's additional skills that you'll get. Now we're going to do that inside of our class, but for the National Registry, they won't ask you a question about an iGel. All right, what do I need to do? What's my role? What's my responsibility as an EMR? Well, number one, and this might sound silly, it's your job to stay healthy, both mentally and physically. It's your job to take care of your equipment. It's nobody else's job, right? It's your job to go to the scene, to go take care of those patients. You need to make sure your scene is safe. That is the number one. Is my scene safe, and am I safe? Is my crew or oncoming patients safe, or oncoming personnel safe? Is my patients safe from further harm? Right? We've got to make sure that all of these things are in fact being taken care of. That's that's part of my job. I need to call additional help. I need to get access to the patient. I'm not just going to leave them there and wait for other people to show up and go, oh well, I knew I needed to do something, I just didn't know what. Right? I need to assess the patient. I need to look at them from head to toe and determine what the problem is, and then do the best I can to administer emergency care to them. If they're broken, I fix it. If they're hurting, I'm gonna help. Right? We need to also remember that we're not just taking care of the patient. We're also taking care of the family. Our kindness and compassion that many forget on gems just today. And today is Thursday, the 12th of January, 2023. There's an article out on GEMS where two basic ambulance people and a couple of law enforcement were responding to somebody who was clearly on an overdose or something, and they were not very compassionate at all, and did some treatments really wrong, and wound up killing the patient, who was not really in life threatening. But we also need to reassure the patient. We also need to reassure the family. And when we don't do our job, when we're not trained, when we're not ready, when we're not compassionate, that could be a problem. And for you guys as an EMR, not necessarily going to move patients until we have the appropriate equipment available, unless it's a life threat. Okay. You might need some help because if you're there first, you may not have enough person power to take care of this. And quite frankly, you might need to kind of control some of the activities of bystanders. Now, I'm not really crazy about me being the one to do that, but I should have called law enforcement to back me up. Or maybe I can have different bystanders be my shield, if you were, to control. Hey, can you turn that radio down? Can you back up a little bit, right? Some other things that I can do is help the EMTs and paramedics as they come on there, making sure to be a good patient advocate for them, making sure that they have what they need, both the medical staff that's coming to assist and the patient. And then here's the probably one of the biggest things is it's not over until you write your report. You need to document your care. Now that might start out as in the field as a field notes, a little half sheet of piece of paper, but that is a legal document, and you have to make sure that you fill it out in its entirety. And quite frankly, if you fill out these field notes, you're actually assisting EMTs and medics because it should be in duplicate form at least. You tear off one, they have their sheet so that they have their base knowledge, right? And then finally, and this is the most important, and documenting care is probably the second most important thing outside of patient care, is you need to keep your knowledge and skills up to date. Taking a class once is not enough. There's a whole series of continuing education issues and components that we'll touch on before we're done with class. We won't touch on it now, but it's up to you to keep up your knowledge base, your license level, your certifications, right? It's not anybody else's. This is your name on a medical license. Make sure you treat it as such. A word about documentation. Use plain English. Uh, Make sure that you're noting things, but you want to make sure also not to use your phone, not to take pictures. That's a violation of rights and so forth. And anything you do is part of the patient care record, the PCR. Make sure that that is all attached in there so that there's a good continuity of care going on there. Also, documentation helps us with training. We did everything by the book, we did everything correctly, and it didn't really work out. We didn't note that, so maybe we changed the procedure. CPR in 2023 is vastly different from CPR in 1970. Right? Vastly different. Why? Because people documented what they did in accordance with what was accepted practice at the time, and these are the outcomes. Right? What can we do better? And they changed things. What should be in your PCR, your documentation? Number one, demographics. Let's go with demographics. Person, first and last name, their birth date, give an actual date, a year number. Right? We also need to then document what did you find when you got there, when you showed up. What was the problem of the illness, injury? Did you do vital signs? I'm here to tell you, you should get at least one set of vital signs. I'm a stickler. I like to have two sets so that when I hand off for those two sets, and then the ambulance takes a third set later on, they can see trending analysis. Are they getting better? Are they getting worse? What did you treat? How did you treat the patient? What agency or personnel took the patient over from you, right? Now, an EMR can only hand off patient care to another EMR or preferably an EMT or paramedic. They cannot hand it off to a civilian. Now, you being at the bottom rung of the medical line, if you will, it is good. It's hard to hand down from your location, but you can't just leave a patient. I gotta go to work. Granny grunt. I leave the patient in your care until the ambulance gets here. No, not a good idea. And then any other interesting facts about the day, maybe you want to make a note of how the scene looked, so that years from now, when your report is pulled up and the prosecutor wants to ask you a question, you can review your notes and know what was going on. Your attitude. To be a good EMR, you need to have certain attitudinal characteristics: honesty, integrity, motivation, advocacy. These are things I don't know if we can train you with. We can tell you what you need and how you're supposed to conduct yourself. But there are scores and scores of people who have gotten their licenses and then proved that they don't have these attitudes. Guess who's no longer licensed? And some of them have actually been put into prison. Actually, going back to that GEMS article, those two paramedics that were working, they're being held on murder charges. Now, as you review the body cam, it doesn't look bad at all. But the compassion wasn't there. Had they felt empathy, had they felt compassion, they might have done it just a slightly bit differently, and the outcome would have been totally different. You're there for the patient. You're not there for your attitude. No one cares how cool you are. No one. You should also not look like a scuzzbag. This young man right here, he looks the part. He's got his shirt on. He's got his EMS pants on. He's ready to go. I just in looking at him, I trust him to start doing his job. I don't have a sleeveless T-shirt on. I don't have ripped jeans on. I don't have uh, all kinds of weird things in all kinds of weird places. I'm there to help the patient. I'm going to look professional. Back in the day, we used to have smocks. We'd be running in from wherever we were to jump on the ambulance and do our job. Well, sometimes we were wearing those T-shirts, right? Well, so we threw on a smock so that we had something that identified us as EMS, but also then gave us some pockets and things so we could do our jobs better and look the part. Right? We should look the part at all times. All right. Again, we talked about this earlier, but a physician or a medical director is the overall leader in the medical care system. This person is not in the field, typically. Okay. So this person is the oversight for all systems, for all pre-hospital systems. They're in charge of the paramedic, the advanced EMT, the EMT, and the EMR. Anybody with a medical license in the state of Michigan, in their area actually, they have control over. They can say, yes, you can work in this area, no, you can't. And they have both online and offline medical control protocols, right? So if I don't have to call into the doc to do something, that's called offline. That's a standing order, if you will. All right. But if we need to call in to do a procedure or administer a medicine or whatever, now we have to call online medical control. There is always somebody in med control. That's why I say it's not necessarily one person. There's somebody at the top of that organizational chart, obviously. But when we call for medical control, we're calling a hospital, basically. And it makes sure that we are getting everything right. We want to make sure that we're doing things right. We don't want to chance doing something that we want to do just because we saw it in a movie at some point. Typically nowadays, we use cell phones. Um, there's still a wide use of two-way radio. In either case, it's on a recorded either channel or phone line. It's not something where it's like, well, I talked to him. No, you didn't. Yes, I did. No, no. It's on a recorded line. Then we get into the quality improvement, where once we're done with the call, we write a report, we do our reviews, and now we start finding things that we can do a little bit better at, right? And we want to make sure that we're evaluating for effectiveness and safety in our treatment plans and in our policies and procedures that implement those treatment plans. Okay? And some of the components that you want to keep your brain wrapped around will be listed right here. Right? We want to make sure that, and this can go on for a couple of slides. Uh, what are the things that we want to make sure of that we're working on? Well, number one is safety, right? What is it that this scene specifically um, caused a safety issue with, right? Because we want ourselves safe, we want our crew safe, we want our patients safe, and we want everybody else to be safe. Something else to be thinking about is effectiveness. Did what I know do anything for the patient? Did it help them? Did it hurt them? If it helped them, is there a way to do it better? If it hurt them, what is a different way to that could help them that would not hurt them, right? Were you and are you, uh, or are our treatment plans patient centered, right? Meaning, are we responsive to the patient's physical needs, her or his uh, internal needs? You know, do they have? Hey, can I call a pastor for you? Do you have a religious somebody that you want me to call for you, or what can I do for you in that instance? I'm going to be focused on the patient, and then do we have a list that could help other providers at a different moment in time? Hey, if you need to call the I don't know, if you need to call Goodwill so that people can get some clothes or Red Cross, you know, here are the numbers, right? How fast did we do our procedures? Did I do what I needed to do in the time that I should have done it, or was I dinking around? Or did I rush through and not take my time to get it done? And then finally, of the last six components, the efficacy, or efficiency, not efficacy. I don't know why I said efficacy. Uh, did I do it with the least amount of supplies used? Because let's face it, in the supply chain issues that we've been having the last several years, we don't have unlimited resources. And so because of that, we need to be mindful of taking care of what we have so that we have more to use for our next patients. And the final thing, equitability, easy for me to say, right? Everybody gets treated the same. If two people had the exact same issues, then, you know, start on the left hand, start on the right hand. Um, you should not base it on anything but what you see medically or traumatically in front of you. All these other things don't matter, because you could go into history and see where some people have done some pretty horrific things in the name of, well, we shouldn't treat these people, we should treat those people. Finally, for this chapter, just as a reminder, your certification is your certification. Once you are certified as an EMR from this class, you're going to follow those national and state standards for your level of certification. Remember, you have the scope of practice, which is the things that you can do. I write that down. Scope of practice equals the things that you can do. Standard of care is how you do them, right? But it's your responsibility to stay current with that knowledge base, right? I'm only going to give you what you know, what I know up to right now. Something might change tomorrow. You need to continue your education. You need to keep your skills update. And quite frankly, if you don't, you might get in trouble for it. All right? So those are the things that you need to know when we talk about EMR. I have a couple of review slides for you here. Let's talk about just a summary, real quick summary. Remember, the EMR is the first person that's typically on scene, trained person. Remember that typically speaking in the EMS system, it starts with reporting, then it goes to dispatch, then it goes to emergency response, which is typically you. Then we get some vehicles going on in there, and we transport them to the hospital. You need to know what to do, how to do it, how to improvise, and how to help others to get the job done as well. You need to make sure that you take care and remember that your job is to take care of the sick and injured patient. That is the biggest deal. And you want to make sure that the next person that's taking care of them has what they need as well. You need to make sure you document everything you do, make it clear, make it concise, make it accurate, and make it so that it is in line with your rules and regulations for your company. Remember that medical information about the patient is confidential and should only be shared with other medical personnel directly involved in the care of the patient. Make sure that the overall leader of the medical care team, you remember that it's a doctor, okay? That it's a physician, it's a medical director. Remember that that's the top thing, and that below the doctor you have paramedic, advanced EMT, and EMR. And then don't forget, we want to always get better. Safety, effectiveness, patient-centeredness, timeliness, efficiency, and equitability. Okay? So those are the things that you are going to be working on as you start to train for EMR.